And we currently transplant kidney, pancreas, and heart at our institute. And as the numbers of transplants grow, I think it's important for us clinicians to be aware of how to prevent and manage these infections in these recipients. And so we're fortunate to have Dr. Michael G. Ison here today with us, who will be presenting on infections in transplant recipients, epidemiology, evaluation, prevention, and management at this morning's Grand Rounds. Dr. Ison received his medical degree at University of South Florida College of Medicine in Tampa, Florida, and completed his ID fellowship at University of Virginia, followed by Transplant ID Fellowship at Massachusetts General in Boston, Massachusetts. Dr. Ison is a professor in the Division of Infectious Disease and Organ Transplantation at Northwestern University in Chicago, Illinois, the Director of Transplant and Immunocompromised Host Infectious Disease Service, and the Director of Northwestern University Clinical and Translational Science Center for Clinical Research. Dr. Ison is heavily involved in research in both solid organ and hematopoietic stem cell transplant, with focus on viral infections, including norovirus, CMV, and respiratory viral infections. And so without further ado, Dr. Ison, thank you so much for being here with us. I will let you take it away.
Great. Thank you so much for the very kind introduction, and it's a real honor to be talking with you today. I do have to say, looking at some of the talks that you have coming up for Grand Rounds next week in particular, I would love to see. I think it'll be a great talk. What I hope to do today is talk a little bit about infections in transplant recipients. Here are my disclosures. And this is what I'm going to focus on over the next 45 minutes or so. I'm going to talk a little bit about the approach to patients with post-transplant infections. And then I will look at how we can prevent some of these infections. How can we expand the donor pool in a thoughtful way? How can we make sure our patients are appropriately vaccinated? And then talk about ways that we can use antimicrobial prophylaxis to prevent infections. I'll then review some common infections that we see post-transplant, cytomegalovirus, diarrhea, urinary tract infections, and then briefly talk for a few minutes about unique features of COVID-19 in the solid organ transplant population. Lastly, I'm going to talk about hyperaminemia syndrome and lung transplantation. I think it's a really cool story that we've been involved with here at Northwestern. And for me, one of the things in Transplant ID that I'm most excited about. So let's first start by the principles of transplant infectious disease. The first is that you have to make a diagnosis. And now this may seem odd, we always make diagnoses, but if you think about our approach to most common infections, we do syndromic diagnoses. Someone comes in as an infiltrate on their chest x-ray, they have community-acquired pneumonia, we may send off urine, strep and Legionella, maybe send off a sputum culture, but even if those are negative, we'll give them an empiric course of antibiotics and send them out. In our transplant patients, there's a number of unique features. Number one, they've been hospitalized and in the healthcare system for a very long time, so they're more likely to have multi-drug resistant pathogens. They're immunosuppressed, so they may have opportunistic infections that are presenting as a very classic presentation. And then the most important reason is that it's very challenging sometimes to recognize that a patient may have a infection in the post-transplant period because the immunosuppressive therapy modulates the host immune response. And if you think about how we tell that someone has an infection, it's the heat, warmth, inflammation, and infiltration of the tissue that allows us to recognize the infection. These are reduced and mitigated by the immunosuppressive therapy that the patients are on. So they may have something going on that we can't readily find based on our standard testing. As a result, we need to do more invasive procedures. Our patients may get a bronchoscopy or a colonoscopy. And you'll hear as I'm going through some of these evaluation steps that they do include things that we wouldn't normally do in our otherwise healthy patients. We have to think broadly with these patients. They're more likely to have infections with Pseudomonas, for example. They're more likely to have MRSA, VRE, and multi-drug resistant gram-negatives. And so we tend to start with a broader range of antibiotics. Additionally, patients, because of that reduction in the host inflammatory response, are also typically 1 to 2 days further along in the clinical course of their disease than you and I would be with the exact same uh, infection. And as such, these patients without antibiotics may get very sick very quickly. And so again, we want to give that broad therapy as soon as we start thinking that the patient has an infection and pare things down as we get information. Renal function is almost universally abnormal in these patients. And this is critically important because many of our antibiotics are cleared through the kidney, and therefore we have to make sure that we have the dosage adjusted appropriately. If we give too much of the medication, they may get toxicity, cytopenias, or other toxicity. And if we give too little, we can drive the emergence of resistance in these patients, something that's a real problem, particularly with drugs with a narrow therapeutic window, like ganciclovir, for the treatment of CMV. Now, it's obvious that a kidney transplant patient with one functioning kidney instead of two will have a reduced renal function. But even for non-kidney transplant patients, the underlying diseases that led to their transplant may have altered their kidney function. They may receive therapies either before or during the transplant, such as tacrolimus, that cause continual loss of renal function the longer the patient is post-transplant. So this is something that we just always need to have in the back of our mind. Next, we need to remember that steroids are oftentimes a component of the immunosuppressive therapy. Even in centers that are steroid avoiding, the patients will get boluses from time to time for rejection. They may get a large amount of steroids around the time of the transplant. And so adrenal insufficiency is a very common problem in this population. In fact, it may be the reason why the patient is having fevers and fatigue that brings them into the hospital. Likewise, you have to be thinking about adrenal insufficiency as we're going to be doing invasive procedures that will induce stress in these patients. And so again, you don't want to induce adrenal insufficiency with some of the things that we're going to be doing in patients. And so it's important to have this in the back of the mind, consider stress dose steroids and or checking cortisone stim tests to see if they are adrenally insufficient. And then lastly, always think about lowering your immunosuppression. Some infections, a urinary tract infection, probably isn't needed, but if someone's desperately ill in the ICU, has an opportunistic infection, this is at least in part occurring because of the degree of immunosuppression that the patient has. And modulating that immunosuppression is going to be critical. Next, we want to think about how do we risk stratify patients and start thinking through which type of infections the patient may have. There are three key things that we always keep in mind in approaching a patient with post-transplant infection. The first, which is what we use in all patients, whether they're transplant or not, is what's the epidemiologic exposure? Have they been exposed to someone that has a COVID-like illness? Have they traveled someplace where they're maybe exposed to endemic mycosis or have acquired a particular infection? These may give you clues to what is going on with the patient themselves. Second, you need to assess what their net state of immunosuppression. The more immunosuppressed they are, the more likely it is an opportunistic infection. The less immunosuppressed they are, the more likely it's going to be a community-acquired infection. Now, this isn't something that we can do a test or develop a score that tells us how immunosuppressed a person is. You have to synthesize a range of data. You have to know what immunosuppression the patient is currently on and what they've been exposed to in the past. For example, many transplant patients will get lymphocyte depletion. This isn't going to show up anywhere on the medical record. You just have to know what your transplant center's induction therapy is. And in centers such as your own, you may get patients coming from other centers. So you always want to ask either the patient or the transplant center what they used for induction. Lymphocyte depletion leads to prolonged CD4 lymphopenia and persistent risk of opportunistic infection, for example. Also, you want to look at what has been going on with the patient. Just because their tacrolimus level today is 8 doesn't mean that it was very high last week or very low. They may have gotten treated for rejection a week or two ago, and again, that may not show up on their current med list. You want to look at a range of other factors. Do they have functional immune defects? Do they have autoimmune conditions enhancing their degree of immunosuppression? Do they have mucositis or catheters that overcome the most important part of our immune system, the skin and mucous membranes? Do they have fluid collections that aren't being surveyed by the cells of the immune system? And are they neutropenic, either intentionally or unintentionally, or lymphopenic, again, either directly or indirectly at the plan of the transplant team? Do they have certain metabolic conditions? Do they have ongoing uremia? Do they have malnutrition, diabetes, or ongoing cirrhosis that's further immunosuppressing these patients? And lastly, do they have ongoing viral replication with things like HIV, hepatitis viruses, or CMV and EBV that enhance the net state of immunosuppression in these patients? The third thing, and probably most important thing that synthesizes a lot of these issues, is the time post-transplant that the patient is. There's generally 3 time periods for solid organ transplant patients that we consider. The first is in the first month post-transplant. This is where the majority of infections, 98+% of the infections, tend to be things that any surgical patient would have. They're a consequence of being intubated with pneumonias, having lines in, bloodstream infections, having a urinary catheter in place, urinary tract infections, or having the surgeon's hands in their body with surgical site infections. They received antibiotics and so are at risk for C. diff colitis. Because of all of these things, it's generally a standard approach. Again, they're more likely to get infection because of the immunosuppression and some of the underlying medical conditions, and it may be more complicated to evaluate. These patients need really early imaging, particularly of the transplanted organ, to make sure that there isn't a local infection from a leak of one of the many anastomotic sites that they have incurred. Rare infections that occur less than about 0.2% of the time are donor-derived infections. These are infections that weren't recognized as present in the donor, but are oftentimes recognized after one or many of the transplant recipients become sick with a similar cluster of of symptoms. The way to think about this is when your patient has an atypical course, or if you have multiple patients that have the same complications. Anytime a patient has a bacteremia, a abnormal course, or illness in the first 30 days should really prompt thinking of donor-derived infection. The only way you'll know if other patients have illnesses is by asking. The formal way to do this is to contact the transplant center, and they know how to communicate with the organ procurement organization and the national transplant authorities as required by OPTN transplant policy to collect information from other recipients. The other type of infection that occurs in this time period is the recipient-derived infections. These are things that the patient may be incubating and missed. We've had at least one case, for example, of COVID-19 where the patient didn't disclose that they had a sore throat and achiness starting right before they came into the hospital. They tested negative, but day 5 started having fever and were found to have COVID-19. Likely this represented something that was incubating the patient and developed early post-transplant. After the patient moves out of the 1-month period into the period from 6 to 12 months post-transplant, this is when the patient is most immunosuppressed. Our immunosuppressive therapies take out different components of the host immune response, and that impact isn't instantaneous. As we all recognize, there's a complex array of connections in the immune system, and it takes somewhere between 1 to 2 months for this to have maximal effect of immunosuppression of these patients. As a result, this is when most of our opportunistic infections occur. These are the things that we think of in our HIV patient population, but were first recognized in this immunosuppressed population. The timeline can be modulated by the use of prophylactic medications. If we use trimethoprim to prevent pneumocystis, that'll be delayed. CMV, again, will be delayed until after the therapy is stopped. And so, for example, when we use prophylaxis in the case of CMV, while the majority of CMV without prophylaxis happens at the 1 to 2 month mark, it actually happens 1 to 2 months after the medicine stops. So if you give 6 months of prophylaxis, you'll see the peak of CMV at about month 7 post-transplant. As the patients move past that 6 to 12 month period, immunosuppression comes down, the host immune response normalizes to the insult that happened to the patient. Any lymphocyte depletion begins to wane in these patients. And as a result, the majority of infections, probably 90% of infections, are the same infections you and I would get. These are things like pneumonias, urinary tract infections, respiratory viral infections. Rarely, opportunistic infections will occur during this time period, or infections that are more common in the transplant population. Whenever these occur, again, it's really important to think to yourself, what's going on with the patient's host immune response, and is there something that I need to be doing because to minimize their risk? So thinking about how we can minimize the risk of infections in individuals, this starts by screening the donor. Currently, it's required to do HIV, Hep B, and Hep C testing. This is generally with serology, with hepatitis C, PCR or NAT testing. Very shortly, it's going to be required that HIV, Hep B, and Hep C are all tested by PCR technology. Syphilis screening in a standard way, CMV and EBV serology, and among deceased donors, blood and urine cultures, and if lung is being procured, usually BAL cultures are collected. For living donors, and it's recommended for deceased donors as well, is to assess them for endemic infections and screen them if they're coming from an area where strongyloides, tuberculosis, Chagas, or West Nile virus, for example, is more prevalent. Most of the screening has relied on serology. The challenge with that is you have a potentially long window period between initial infection and detection of the serologic result. That has led to the use of PCR-based testing, which really helped narrow that window pretty significantly. But we have to recognize a PCR test doesn't drop the risk to zero. And in fact, even with PCR tests, there is a window period for them. So if a person overdoses with drugs, now, unfortunately, a relatively common contributor of our donor pool are individuals that have overdosed. If they inject hepatitis C with that fatal injection, even a negative test in the first 5 to 7 days after their death may still not reduce the likelihood that they have an undiagnosed infection and may be missed by these tests. As a result, we're very cautious to screen these individuals post-transplant. Again, policy around this is in the process of changing. Historically, we had to get special informed consent for these patients and do testing just in this subset of patients receiving organs from donors that were at increased risk of having these infections. Over the course of this year, that's going to become a more universal approach to these patients. Now, we've learned a lot through using organ donors and through collecting national data on individuals with infections. We have increased the use of what we call increased risk donors. When I first started doing transplant ID, there was a real fear of these type of donors, and they were highly underutilized, in part because of comfort with these donors and the significant increase with the opioid epidemic. We started using these more and more, and in many areas, they account for nearly a third of organ donors. We've made these safer by the using of universal donor NAT testing to really help shorten that window period of missed infections. We've expanded the donor pool by using hepatitis C infected donors. Again, this has been partly driven by two things: an increase in the proportion of these patients because of the opioid epidemic, but also because we now have really good therapies to treat these infections. And now the trend has been looking at much shorter therapies for these individuals in an attempt to make it more cost effective. Likewise, we're starting to use HIV positive organs and HIV positive recipients, again, adding to the potential donor pool and allowing more people to get transplanted. And then there's an effort. New York has a great system for this. Our area has a great system for this, for engaging the transplant ID team whenever an organ is being turned down because of concern for an infection. Studies of this type of intervention has found almost half of organs that the transplant teams are very nervous about can actually be safely utilized, and again, expand the donor pool without decreasing the organ safety. So moving away from the donor, thinking about the recipient, how can we reduce infections post-transplant? This starts well before their transplant by a pre-transplant evaluation Most of this is done as part of a protocol at the transplant center, where there's a detailed H&P with a focus on travel and occupational history to identify things that may place the patient at higher or unusual risk of infections. Standard serologies with the addition, as I mentioned before, of endemic infections. This will allow more tailored prophylaxis post-transplant and identify infections that could be either transmitted from the donor or that need to be identified and treated to minimize the risk of complications post-transplant. So a common scenario that comes up that you may be asked is you have a patient like this one, a 32-year-old female who underwent a living unrelated kidney transplant 9 months ago. She got induction and maintenance as outlined here, really no infectious complications, and recently adopted a new 6-month child. She calls in October asking about vaccines. And hopefully you tell her that she should get her flu shot and any other appropriate vaccines, and that the child can get any vaccine that's recommended for them. Now, vaccines are really important, and the time to really start thinking about them is before the transplant, but also to keep their transplants up to date. If there's a reason to give someone a live virus vaccine, either they don't have immunity to varicella, they want to travel to a yellow fever endemic region, for example, post-transplant, it's important to give them to the patient pre-transplant because they're contraindicated in the post-transplant period. Additionally, pre-transplant vaccination improves post-transplant response for things like the flu shot, which is given at regular intervals. You can reduce mortality on the wait list by giving things like hepatitis A and hepatitis B vaccine to the liver transplant patient. You can increase the organ pool. Now about 4% of organ donors are Hep B core antibody positive donors. The risk to them acquiring the infection is very low if they've been appropriately vaccinated. Every year, this year we probably won't because there's so little influenza, but almost every year we have a patient come in with active influenza when they're called in for transplant that causes them to lose that transplant themselves. In the post-transplant period, it's critically important not only to vaccinate the patient, but their family members against influenza every single year. It's safe, as I'll show you on the next slide. Likewise, Prevnar and Pneumovax, that should be Prevnar 13, not 16. Part of the concern about vaccines in the post-transplant period is that some of the early studies, particularly with influenza, suggested that there was increased risk of rejection and poor efficacy of these vaccines. Unfortunately, that wasn't borne out by well over 40 studies looking at influenza and other vaccines in the solid organ transplant population. What we have seen relatively consistently is shown here from one study in which the dark line is individuals that are transplant patients, and the dashed line, their healthy spouse or a loved one that takes care of them. What you can see is that the peak titer after the vaccine is much lower than in a healthy individual. That is important because the peak titer determines the duration of time that the patient is protected in the post-transplant period. This is important, as we'll talk about shortly, because I think this will be something that we need to think about when coming up with plans for COVID-19 vaccines. For the most part, any inactivated vaccine is safe to give post-transplant, but those live virus vaccines are contraindicated in the post-transplant period. That was for children. This is for adults. And then a very common question relates to contacts of transplant patients. With the exception of the smallpox vaccine, contacts of the transplant patient can get any vaccine that's indicated for them. They don't need to change their behavior with the child or loved one. They should just avoid touching the vaccine site and washing their hands after changing a diaper in these individuals. In terms of the SARS-CoV-2 vaccine, unfortunately, we have very limited data in this patient population. That being said, it's all about a risk-benefit assessment. There's nothing about the currently approved vaccines that would be anticipated to increase the risk of rejection. And as a result, the current recommendation is to give the vaccine to immunocompromised patients. There weren't any stem cell transplant or solid organ patients included in the studies to date. So we do need to collect some data to see, do they have reduced response to the vaccine, and is the duration of protection shorter than normal healthy individuals. Optimally, the vaccine should be not given within the first month after the transplant, and we should try really hard to avoid giving the vaccine between, so that the transplant happens between the two doses. So if you have a living donor transplant, if it's safe, it's recommended to wait to either vaccinate them after the transplant or defer the transplant until they can be at least 2 weeks after their second dose of the vaccine. It's a standard of care to give individuals peritransplant prophylaxis. This starts with the procedure itself, where standard antibiotics cover skin flora and the flora in the area where they're doing the surgery for about 24 to 48 hours. It's also considered standard of care to prevent pneumocystis jirovecii. Traditionally, this has been recommended for 6 to 12 months, but more and more data is coming out that shows that really the benefit is such that it should be continued lifelong, and that's the approach we use in our patients. The first-line therapy should always be trimethoprim sulfa because it provides benefit for things far beyond pneumocystis. The dosing, whether it's single or double strength, once a day, Monday, Wednesday, Friday, or even Tuesday, Thursday, really probably doesn't matter from the protection of pneumocystis, but for things like prevention of urinary tract infection, other infections, more frequent dosing may be required. Second-line therapies for sulfa-allergic individuals, tovacone is our preferred second-line agent because dapsone, you have to remember, it cannot be used in patients with G6PD deficiency, and even among those with normal levels of G6PD production, about 12% of individuals post-transplant still develop hemolytic anemia. Pentamidine is an option, but we don't like to use it because the patient then has to come in every month. Something they can do early post-transplant, but they aren't happy about post-transplant or later post-transplant. CMV I'll get into in a little bit more detail in a few minutes, but if you're not going to give prophylaxis against CMV, you do need to give prophylaxis against herpes or varicella. This can be accomplished with acyclovir or valacyclovir. And then urinary tract infections, particularly in kidney transplant patients while the stent is in place, which usually is somewhere between 2 and 6 weeks after the transplant, can be accomplished by trimethoprim sulfa, but if someone's sulfa-allergic, they would need to receive an alternative agent such as cephalexin or fluoroquinolone. Now, the last thing that I'm going to focus on in the kind of peri-transplant issues is to think before you prescribe. You may be seeing a patient that's being admitted to the hospital, and there's a couple of key tenets that you want to be always thinking about. First, remember that fact. They almost always have renal insufficiency, so make sure that you're dosing the drug appropriately. Second, many drugs interact with the common immunosuppressive medications. The two classic ones are the azole antifungals, voriconazole being the most potent, similar to itraconazole, slightly more than you would see with posaconazole and more than fluconazole, particularly when you're using low doses like 100 or 200 milligrams once a day. But nonetheless, it's important to remember that you need to adjust the drugs when you're starting the therapy, but also have a plan for when you're stopping that therapy at some later time point. Macrolides, really, we should do everything we can to avoid the use of clarithromycin and erythromycin in this patient population. And if a macrolide is indicated, consider the use of azithromycin, which has less drug interactions and generally can be safe in these patients. There are two common drugs, fluoroquinolones, particularly moxifloxacin and ceftriaxone, that we use a lot in our patients and really don't have a lot of interactions in the short term. But if you're using those therapies for beyond 2 weeks, you'll oftentimes see a slight drift in tacrolimus levels going up. So again, something you need to be thoughtful of when using these therapies. Rifamycins basically have the opposite problem. They drive the levels very low and may make it impossible to use things like sirolimus or everolimus while taking these therapies. If you do need to use one of these therapies, rifabutin is preferred over rifampin because it has less of an impact on the cytochrome P450 system. Next, you want to think about synergistic toxicity. Antivirals like Valium, cyclovir, and cidofovir enhance the risk of neutropenia. And so again, you want to have a plan for reducing other antimetabolites like mycophenolate when these are started. Nephrotoxins like aminoglycosides or amphotericin increase the risk of renal damage in our transplant patients, and again, should be really only used at the direction of the transplant ID team. Now, let's move into some common post-transplant infections. CMV is a really interesting virus. It's activated by a number of things. Its most potent activator is TNF-alpha, which basically if a patient is having fever, you can tell that there's plenty of TNF-alpha around. That activates a cascade of reactions that activates the promoter of CMV, two genes from the virus that are constantly produced, even in the latent stage, that binds to a cellular marker, NF-kappa B, that enhances replication of CMV. This is further enhanced with the use of steroids as well as other medications. We can reduce the risk of CMV by doing things such as screening the blood products that we're giving for patients. And in general, patients should have either leukoreduced or CMV negative blood, particularly if the donor and recipient are both CMV negative. Active immunization is something we would like. We've failed many times. It's still an experimental option. Passive immunization using IVIG or cytogam is something that can be considered, but really has fallen out of favor with the use of potent antivirals. And the approaches that can be used is universal prophylaxis, where everyone at risk gets the prophylaxis for a fixed period of time, or preemptive therapy, where people get monitored and only receive therapy once the positive signal comes up on the test. Hybrid approach, where you give universal prophylaxis for a short period of time followed by preemptive monitoring, is being used, although the evidence to support it is relatively weak. Many prefer to use universal prophylaxis because it is associated with better graft outcome. In this image, which is a little bit blurry here, so sorry about that. The top line is patients that receive universal prophylaxis. The bottom line is those that receive preemptive therapy, where you have a much lower incidence of acute rejection at the 1 year. Again, why many centers, particularly in the United States, preferentially use universal prophylaxis. Our current prophylaxis is driven by this study that randomized patients to receive oral ganciclovir, which is very poorly bioavailable and now no longer available to us, versus oral valganciclovir, the standard of care for our patients. They received 3 months of therapy, and valganciclovir was associated with a marked reduction in the incidence of CMV at 3 months. But unfortunately, at 1 year, nearly half of patients had developed CMV viremia. As a result, this led to a study that extended prophylaxis to 6 months and found that, in fact, 3 months of prophylaxis had double the CMV than those patients that received 6 months of prophylaxis. As a result, standard of care is to use 6 months of prophylaxis for patients that are high risk, donor seropositive, recipient seronegative, or have received lymphocyte depleting antibodies. Like everything, you don't get anything for free. The longer duration of valganciclovir is associated with a higher rate of neutropenia in these patients, and so many times these patients will require a dose or two of G-CSF, which is a bit of a nuisance. Once the patient develops CMV infection, whether this is CMV viremia, pneumonitis, intestinal disease, the question is how to treat these patients. And historically, we only used IV ganciclovir until the studies shown here, which randomized patients with mild CMV, meaning that their CMV viral load was below somewhere between 50 and 100,000 copies, that didn't have CMV pneumonitis or GI disease. As you can see, the lines of oral valganciclovir versus IV ganciclovir are identical. They cleared the virus in the same way. And this led us to our current paradigm that we need to treat the patient until eradicated. Typically, we require 1 negative value before the patient has their therapy stopped. Some centers still are using secondary prophylaxis, although the data to support this is a little bit weaker. We use it for selected patients that have received potent lymphocyte depletion, and that oral valganciclovir is the appropriate therapy to treat most episodes of CMV, unless they have severe disease, generally a CMV viral load above 50 to 100,000, evidence of pneumonitis, or evidence of GI disease. Next, a very common issue is diarrhea. If you take a very careful history, about 60% of individuals will have at least one episode of diarrhea per month in the post-transplant period. Many patients will have intermittent or persistent soft or mushy stool. And so it's something that's very common. The challenge is that many people kind of do a very haphazard approach and can miss some of the most common causes of diarrhea in this population. To deal with that, we developed a standardized protocol, which we're still using at Northwestern, in which all patients with diarrhea get a stool culture, C. diff PCR, Giardia and cryptosporidium EIA, a PCR for norovirus, and a serum CMV viral load. If this workup is negative, we reduce the mycophenolate. If that doesn't improve the diarrhea, they go on to colonoscopy. So with that, we retrospectively looked at about a year and a half worth of patients and found that, not surprisingly, the majority of patients didn't have a cause of diarrhea identified. Not surprising, probably means that it was the drugs that they're receiving for transplant that are causing the diarrhea. C. diff was hands down the most common infection, occurring in about 13% of patients with diarrhea that started in the community. But I think surprising to us and many was that norovirus was incredibly common in these patients at or slightly greater than the frequency of CMV. Everyone up to this point was very diligent about checking for CMV, but we did a very bad job of checking for norovirus. And in fact, what we've learned about norovirus is that it is incredibly common in these patients, and it can have a pretty significant impact. The duration of diarrhea is markedly prolonged. In this retrospective study from our institution, there was a median of 135 days of symptomatology, although many of the patients still had ongoing diarrhea at the end of follow-up, meaning that it's likely much longer, whereas non-noroviral diarrhea tends to be a lot shorter. Sometimes it can be very long. You can see this one patient that had 2,500 days with diarrhea. She, in fact, had multiple hospitalizations from recurrent dehydration and ended up losing renal function and needing a kidney transplant because of the norovirus. We had 2 patients that died from complications associated with norovirus, and a third of patients had a greater than 20% decline in GFR at 1 year, again, reflecting the recurrent episodes of diarrhea. The optimal approach to these patients still remains to be defined. We have a study looking at norovirus at multiple centers around the United States. But until we have a proven therapy that works, our approach has generally been to be aggressive with antidiarrheals. This generally controls symptoms, prevents the dehydration, and allows the patient to have much more normal renal function. Urinary tract infections are incredibly common in the post-transplant period, particularly in the kidney transplant population, but are likely over-treated. What we have learned, the old dogma was that anyone with a positive UA and evidence of bacteria in the urine in the past needed to be treated, whether they had symptoms or not, because of fear of pyelonephritis and complications of the graft. This is one of the first studies of now nearly a dozen that have proven quite definitively that asymptomatic bacteriuria in a kidney transplant patient really does not lead to pyelonephritis or graft dysfunction in these patients and does not need to be treated. This is important because kidney transplant patients get urinalysis very frequently, and it's not unusual for them to have leukocyte esterase and even potentially a bacteria identified. The very first question you need to ask the patient before even remotely considering treating the patient is, do they have symptoms? Smelly urine, by the way, is not a sign of urinary tract infection. It's a sign they need to drink more water. They really need to have pain, burning, frequency. And remember, these patients won't have flank pain because the kidney isn't in the flank and in fact is not innervated. Most cases of cystitis, again, need to have symptoms with a positive UA and a high bacterial load greater than 100,000 colony forming units. You don't want to use fluoroquinolones as your first-line therapy in these patients. There's currently a black box warning against its use. Risk of tendinitis and C. diff as well as resistance is a real problem. Nitrofurantoin is an option for these patients, but you have to be careful in patients with elevated creatinine clearances. And trimethoprim sulfa is really not something that should ever be used in transplant patients. The bacteria should be resistant to this class of drugs because it's used so widely for prophylaxis, and high doses can induce renal toxicity in these patients. So the first line therapies currently are oral cephalosporins, typically first generations, but this has to be modulated to your host, to your local antibiogram. For patients that have extended spectrum beta-lactamases, fosfomycin and nitrofurantoin frequently are susceptible, but again, you want to get susceptibilities to make sure that they are susceptible. The first thing you want to ask, particularly early post-transplant, is the stent in place, because if the stent is, you want to make sure that the antibiotics are continued until the stent is removed, not just the 7 days that is typically used for the treatment of these patients. If the patient has recurrent urinary tract infections, think stones, see if they need to have a urologic evaluation, and think about non-antibiotic approaches to reducing frequent urinary tract infections, such as the use of methenamine for prevention. Patients admitted to the hospital with pyelonephritis should always have the transplant ID team engaged so that they can optimize the approach to patients. The last infection that we're all becoming much more familiar with is COVID-19 in the transplant population. Olivia Cates at the University of Washington collected data nationally on 482 patients with solid organ transplant that developed COVID-19. The population was very much reflective of where the majority of the cases were, Northeast predominantly in the first wave of COVID-19, and reflective of the general transplant population, mostly kidney transplant patients, although there was a slight over-representation of lung transplantation because of the severity of disease in these patients. In terms of outcomes of these patients, overall mortality was about 20%, so where we would have expected it to be for all comers. There was rare instances of bacterial and fungal superinfections, although they were recognized, and cellular rejection and antibody-mediated rejection were incredibly rare and typically associated with aggressive reduction of immunosuppression. And in fact, the only population that was overrepresented in terms of fatal cases were lung transplant patients, where about a third of those individuals died at the end of 1 month. Interestingly, though, when they went in and looked at the data, transplantation really did not seem to be the key driver of the severity. In fact, it was their underlying medical conditions, race, and obesity that were the main drivers for outcomes. So in fact, while these patients, in part because they have a lot more comorbidities, don't actually have an enhanced risk of death compared to matched patients with similar comorbidities. Again, their overall mortality is still very high, particularly among the lung transplant population. But again, a lot of this is driven not by the immunosuppression, but in fact by their underlying medical conditions. The one exception to that, like I said, is the lung transplant population, which does have about a 10% excess mortality compared to age and comorbidity matched controls. The other challenge with these patients is they have very prolonged viral shedding. I've shown you data from our first 20 or so transplant patients where the median duration of shedding was around 45 days. Some of these patients do have relatively high viral loads, well beyond 20 days. And so again, the paradigm of discontinuing isolation after 10 days is not recommended for this population, and many centers still use a test to clear approach, although if you're waiting for a negative PCR, it will take a very long time. We typically select a CT value that if they have 2 or more nasal swabs that are above that threshold, we allow them to be taken off of isolation. Lastly, I want to talk about our first lung transplant patient that taught us about a very important potential cause of a fatal condition in lung transplantation. They were a 44-year-old African-American gentleman with pulmonary sarcoidosis that underwent bilateral lung transplant, did very well, had standard immunosuppression, induction, and perioperative antibiotics. And then on post-op day 7, began to have altered mental status. A very extensive evaluation was negative with except of very high ammonia levels in this patient. We literally threw the kitchen sink at him to help reduce the ammonia without any impact. So our first step was to look at the literature. What is hyperaminemia syndrome? It's a rare complication of lung transplantation occurring in about 4% of recipients. Its hallmark is refractory elevations in serum ammonium, typically in the setting of normal liver function, no evidence of inborn errors of metabolism. Oftentimes there's a stressor that is associated as a trigger with this, and there's been very few data collected nationally. Most of the cases are single case reports that have claimed things like tacrolimus, maybe a driver for this. And we were intrigued because a case from the Mayo Clinic suggested that maybe Mycoplasma hominis that was the driver. Because of this concern, we decided to add azithromycin to our patients' regimen, which resulted in normalization of their ammonia. We sent off testing for Mycoplasma in the blood, and to be blunt, because the test was misordered, it came back with testing negative for Mycoplasma, but positive for another related organism, Ureaplasma ureolyticum. This organism actually uses urea as part of its life cycle and cleaves ammonia as part of its energy production. So at least made some sense as a potential cause of this. It's generally susceptible to macrolides, and as you can see, as the patient's ammonia normalized, repeat testing of the patient was negative. Interesting, we thought. Unfortunately, several days later, the ammonia started to go back up and did not respond this time to azithromycin. Repeat testing showed the ureaplasma was again positive in the blood, and unfortunately the patient herniated, as many of these patients did, and died. An autopsy revealed that specimens from the bladder, liver, spleen, lung, and BAL were all tested and positive for Ureaplasma ureolyticum. And in fact, when we did susceptibility testing, the second isolate had developed resistance to azithromycin and erythromycin, but remained susceptible to the fluoroquinolones and the tetracyclines. This led us to really try to understand what is going on. We reached out to a couple of other centers that had recent cases of hyperaminemia. And lo and behold, when we did testing of residual specimens from these individuals, Ureaplasma ureolyticum or related Ureaplasma parvum was identified in all of these patients. This was even true for the case from the Mayo Clinic, where they had claimed that Mycoplasma hominis was the cause. Ureaplasma was detected in that case as well. We took negative controls from the ICU, as well as negative controls from lung transplant patients that didn't develop hyperanemia and did not find ureaplasma in those samples. Since then, there have been nearly 100 cases of hyperanemia with ureaplasma documented in nearly every single case. And most patients now are recovering. Instead of a 90% mortality, it's a 90% recovery with the early treatment of this infection. So really an incredible story where a discovery has transformed a previously fatal condition into one that commonly is survivable. Infections are a leading cause of morbidity and mortality. Post-transplant infections are common. We need to keep focused on vaccination, use appropriate antimicrobial prophylaxis, and dose adjust therapies as needed. CMV is a common complication of solid organ transplantation. So with that, it's been a real honor talking with you today, and I'd be happy to answer any questions that you may have. Thank you.
Thank you, Dr. Ison. That was very enlightening. I actually have a question for you as we start getting some questions in. Are you at Northwestern using a GI BioFire by any chance?
We are not. Our big concern with the biofire is that you may be overcalling C. diff and some of the bacteria. Based on culture-based testing, we still have very rare. It's less than 1% of our patients have bacterial infections in these patients, and so because of the concern for oversensitivity and perhaps giving you false positives, we've decided not to use that assay.
Okay. Thank you. Does anyone else have any questions? Please feel free to type it in the chat. Or I don't know if you're able to unmute yourself.
Well, if there's no question from you, I have a question for you, Pinky. Have you started vaccinating patients in New Jersey?
Vaccinating for COVID-19?
Yeah.
I particularly have not started on our transplant patients. I can let Dr. Mann, who is the director of renal transplant on this call, weigh in on that. But we have started vaccinating some of our other patients, like our HIV population, et cetera. I don't know if Dr. Mann can answer the question about if they've started vaccinating their transplant patients.
Well, it looks like there's two questions that have popped up. Do you treat asymptomatic bacteria in the first 3 months after renal transplant? The answer is no. We only treat asymptomatic bacteria if the stent is in place, which for us is 2 weeks. In most individuals, some people do if there's certain features in the patient. If they have a small bladder, for example, is one. They may have longer duration of stenting. We will treat asymptomatic bacteria with the stent in place, but beyond that, we do not. There is not a lot of data for that, but again, in my opinion, I don't understand why there's anything different in that time period. It's fear without a lot of data to support it. And then the second question is, what are the options for management of long-lasting norovirus in the transplant patients? So there have been, a lot of people have tried a range of things. Oral IVIG has been tried, nitazoxanide, ribavirin has been used in these patients. Breast milk has been tried, particularly in pediatric populations, and then nitazoxanide is oftentimes used. Having done a lot of work in this area, I'm not convinced any of them are helpful. Some of them, like nitazoxanide, are very expensive, and insurance oftentimes won't cover more than a week or so of therapy, and may cost the patient thousands of dollars to take it over the long run. What is effective is controlling their diarrhea with anti-motility agents. Our approach is to use Imodium in these patients. They will need a lot. The average number of pills that are needed is 16 per day. And so what I typically recommend that the patient does is take 2 tablets with every soft or poorly formed bowel movement. Once they have hit a relatively stable dose for 3 to 5 days, then they can spread that dosing into twice a day tablets. So if they're taking about 16 pills, 8 tablets in the morning, 8 tablets in the evening, with breakthrough therapy as needed. That really does seem to control most of the symptoms and keep people functioning relatively normally with the norovirus. As I've learned, you can get a 200 count bottle for about $5 at Target. With it's generic, or a 400 count bottle for about $7 through Amazon. And so they will need a lot of it. but it's something that's pretty cheap and pretty well tolerated in these patients. You have to be very clear with the patient that they can take as many as they feel is needed to control the diarrhea, because the bottle says don't take more than 10 tablets in a day. They can clearly take more of that safely to control it. I will say my experience with nitazoxanide is it works. And for patients, we do use it in patients that require a very high amount of anti-motility agents. So once they're hitting about 20 tablets of Imodium, or if I'm reaching for things like tincture of opium to control their diarrhea, which sometimes you need to do, then you would effectively consider something like nitazoxanide, which I do find is will allow you to cut back on the amount of medication used to control the diarrhea. So it looks like, oh,
yeah,
sorry.
sorry, I just want to let you know that Dr. Mann actually just wanted to answer the previous question regarding the COVID vaccine. He said that we're following the recommendations of the AST with regard to COVID vaccines. We recommend that patients register for the vaccine, recognizing that transplant patients were not included in the studies of the vaccines. The efficacy and safety are unknown. And then there's another question. Any recommendations regarding what to do with the immune suppressive therapies prior to giving the COVID-19 vaccine?
Yeah, definitely don't do anything. You know, the patient, just as you would with a flu shot, I wouldn't reduce the immunosuppression. I wouldn't modify that. The worst thing you could do is trigger a rejection shortly after, because that treatment will likely markedly reduce the vaccine efficacy. Just like with our flu vaccine, you should give them the shot. They don't need any enhanced monitoring or adjustment of their immunosuppression.
Great, well, thank you. If anyone has any questions, please feel free to type here. Otherwise, I think that may be it, Dr. Ison. Thank you so much for being here with us and joining us and enlightening us with this presentation on how to prevent and manage infections in transplant patients.
No problem. It was my honor to talk with you today, and have a wonderful day.
Thank you.